Hello, everybody. Welcome to today's webinar. My name is Randy Marsden, VP of Value-Based Care at Anatomy IT, and this is our 2025 MIPS Proposed Rule presentation. I'd like to introduce you to Jessica Peterson, who is our Senior Director of Value-Based Care Policy, who will be leading you through today's presentation. Take it away, Jessica.
Hello, good afternoon to those of you on the East Coast. Good morning to everyone else. My name is Jessica Peterson. I'm the Senior Director of Value-Based Care here, of Value-Based Care Policy, I should say, here at Anatomy IT, and I'm going to take you through the 2025 MIPS proposed rule today. We're going to start off with a quick overview just to level set. Then we're going to go into proposals for an alternative path, but still under MIPS, called MIPS Value Pathways. We'll go over that more in a second. Then we'll go over cost, promoting interoperability, improvement activities, quality, and then we'll have time for Q&A at the end. So just a quick level set. Today we're talking about the Quality Payment Program, or the QPP. This was established by statute, so it is required for CMS to make every year by the Medicare Access and CHIP Reauthorization Act of 2015, MACRA for short. This was a fantastic win for medicine in that it finally got rid of the Sustainable Growth Rate Formula, or SGR, which some of you may remember Congress having to pass those doc fixes every year to avoid a 20 to 30% pay cut under Medicare. So big win, but it did also redefine the rules for the road for value-based care. Mandating CMS to make the QPP. There are two ways to participate in the QPP. One is through advanced alternative payment models, or advanced APMs. These require you to take on financial risk and are largely primary care focused. The other pathway, which we're going to talk about today, is MIPS, the Merit-Based Incentive Payment System. It's the fee-for-service performance value-based track of the QPP. So why is this important? This is important because it can impact how much you get paid under Medicare Part B. So if you do poorly, you'll get a penalty. If you do really well, you'll get a bonus. And the bonus and penalty thresholds for 2025 have no proposed changes from this year. So anything below 75 points, you will get a penalty depending on how poorly you do. It's on a linear sliding scale, so the worse you do, the more of a penalty you'll get. At 75 points, you'll get a neutral adjustment, which means you'll just get what you would normally get without any change. And anything above 75 points, and you'll get what's called the budget neutral bonus. This is also on a linear sliding scale, so the better you do, the more you get. But as I mentioned, it's budget neutral. And what that means is that the total amount of bonus monies for a year comes out of the total amount of penalty monies for that year. So the amount you get is also dependent on how many people get penalized and how many people get bonuses. So how you're scored under MIPS, also there are no proposed changes to the overall scoring. Each category has its certain weight in that it contributes to your MIPS final score. Quality and cost are 30%. This is required by statute, so that's not going to change anyway. Improvement activities is weighted at 15%, and promoting interoperability is weighted at 25%. So that brings us to MIPS value pathways. This isn't something we've focused on a lot in the past because it was new starting this year. So nobody had actually reported on it. What is MIPS value pathways? So it's CMS's attempt to bring us closer to advanced alternative payment models and to align quality and cost measures more specifically. However, because of restraints on how MIPS can be formulated under statute, it is actually quite similar to MIPS. The big changes I've outlined here. So in traditional MIPS, you have to report on 6 quality measures, and you can pick from a large inventory of hundreds of measures. Well, whereas in MIPS value pathways, there's a more limited selection of measures. You are limited to a list of measures that is specific to that MIPS value pathway or that MVP. But you only have to report 4 measures. There is that requirement that one must be outcome or high priority, same as in traditional MIPS. Another thing about MIPS value pathways quality is that there's this thing called the foundational layer of MVPs, and that is something that translates to every single MVP. So every MVP has this. And what's contained in that are the population health measures and promoting interoperability. Now, population health measures count toward your quality score. If you don't meet the case minimum on it, it's as if they weren't there. So they just get suppressed and your entire quality score will be out of 4 measures. So it doesn't penalize you if you don't meet the case minimum. These are those administrative claims measures. Currently, when you register to report on an MVP, you have to select one population health measure. There are only 2 available. However, CMS is proposing a change to this for 2025. And that change is to, instead of having you select one when you register, instead just measure your performance on every single administrative claims measure. Right now, again, there are only 2, but in the future, there will be more. And just apply the highest scoring one to your score. Now, again, if you don't meet the case minimum, the point is moot. It's as if population health measures weren't required. So next up, we have cost. Under MIPS, you're scored on any cost measure for which you exceed the case minimum. And we're going to go over cost in a second. So if you have any questions on that, we'll be answering them soon. Just take it at face value for now. However, under MVPs, you can only be scored on the list included in the MVP, and I'll show you what that means in a second. The other change, again, PI is the same for everybody. The other change is under IA, improvement activities. You get double the weight under improvement activities. There's a big change to improvement activities. I'm not going to go into it here. I have things highlighted that are proposed changes, but it's exciting, and we'll go over it in slides to come. Now, importantly, there are 2 MVPs that are proposed to be new starting with 2025 that really impact our client base. One is the ophthalmic MVP. The proposed title is Complete Ophthalmologic Care. Some of you may be familiar with this from some of our outreach and from your specialty societies outreach. CMS has been building an MVP for ophthalmology for years, and there's been a lot of back and forth. What we really wanted was one that focused on cataracts, since that's the cost measure we have. As you can see here, that is also the cost measure for this MVP. So CMS wanted, however, to reduce the explosive growth that was a potential on, excuse me, under MVPs. So rather than doing an MVP for every subspecialty, they're like, okay, we have a specialty here, ophthalmology. Let's do an MVP that everyone can report. So this is the list of quality measures that is in the proposed MVP. I've color-coded them. If they're orange, they're currently topped out, but not 7-point capped. So they're just topped out. In the future, they may become 7-point capped. If they're red, or there's a collection type in parentheses at the end of the measure name that is red, that is 7-point capped. That collection type or the entire measure, depending on which one is red. And if they're blue, they are not benchmarked. Some of them, for instance, measures 499 through 501, those new retina measures, they're not benchmarked because they're new to MIPS. 2025 will be their second performance year, so they're going to have a 5-point floor, meaning the minimum you can get on the measure is 5 out of 10 points if you report it. Others, like measure 487, is currently in its second year, so next year would be the first year it could be benchmarked based on a previous year. And of note, it did receive a 2023 performance period benchmark. So its first year was 2023, and enough people reported on it for CMS to determine like a retroactive benchmark after the end of the year, something that we either call performance period benchmark, live benchmark, or retroactive. So there's probably going to be enough data for the ones that say received a 2023 benchmark to be benchmarked in 2025. That being said, as you can see, there's still a lot of topped out, and there's still a lot without benchmarks. What's really important, though, is that these measures do not cover every ophthalmic subspecialty. There's nothing here for refractive. There aren't enough measures for cornea. There's nothing here for neuro-ophthalmology, oculoplastics, or pediatric ophthalmology. So this really doesn't cover the comprehensive set for complete ophthalmologic care. So we did discuss this with CMS before the proposed rule, and we included a list that we would recommend. They took some of those recommendations, but not all. If this is going to impact you, and if you're an ophthalmologist, it will, because of something we're going to talk about in a minute, please comment on this. Comment on how this will impact you. Your comments make a huge difference. And I'm going to walk you through at the end of the presentation how to do that. Okay, so that's it for ophthalmology. There was also a new dermatology MVP proposed. This one is, as you can see, even more troublesome, not because of the lack of subspecialty coverage, because dermatology isn't quite as siloed as ophthalmology is, but because of the sheer number of measures that are either not benchmarked or are 7-point capped. As you can see, there are only 2 measures in this proposed MVP that are neither topped out, that are both not topped out and have a benchmark. Some of these will probably have enough information to receive a 2025 benchmark. This is based on current benchmarks for 2024, because the 2025 benchmarks won't be released until 2025. So this is the information we have to work with. There are obviously concerns here. It does include some good measures that are new and might receive a benchmark in 2025, but there are concerns. So if you are concerned about this, please do comment, write to CMS. Again, I'm going to talk to you about how to do that later. And the American Academy of Dermatology will be coming out with a more detailed analysis of their likes and dislikes of this MVP in the coming weeks. So watch out for that as well. And the cost measure for this one is the melanoma resection cost measure, which is the only dermatology-specific cost measure. All right, and now this is why it's so important. Previously, CMS has made it very clear that they want the transition from what we're now calling traditional MIPS, the MIPS that we all know and love, to MIPS value pathways or MVPs. They want to make that a mandatory transition. Previously, they floated 2026, they floated 2027, but they never really came out with a firm timeline. It was more kind of, we're thinking maybe this, we're thinking maybe this. In this rule, there is not a proposal, so nothing can be finalized, but they have come out with a detailed timeline on the transition. Specifically, they want the last year of MIPS to be performance year 2028, and then the first year that MVPs are mandatory to be 2029. They're requesting comment, they're requesting feedback on this before they propose anything. So if you do not think that MVPs are there yet, which I don't think that we're going to have enough specialty coverage for this to really be a feasible pathway to be mandatory, please do tell CMS that. Again, your comments matter. All right, and now we're done with MVPs. So let's move on to traditional MIPS, the one that most people will be reporting on. First up is the cost category. So these are measures related to resource use or cost of care. This is a full year performance period. There were no proposed changes to these basics. The number of points that you can get within the category depend on how many measures you're scored on. So if you meet the case minimum, which again, I'll show you some examples of in a second, on a measure, that measure is worth 10 points. If you meet it on 2 measures, then your total category score will be out of 20 and so on. It's scored in real time, so we don't get any feedback during the year, and we can't estimate what your score is going to be. And it's worth 30% of your MIPS final score. There are bonus points. So if you do better in the cost category than you did in the previous year, then you can get up to a 1% bump in your cost category score. And again, it's based on administrative claims data, so there's no work to do as far as reporting. There is one very big change proposed to how the cost category will work, however. CMS is proposing to change the way they score cost measures. Preview, I love this proposal. So the current way they score measures is to split the dollar ranges, so the cost ranges that they see in a given year, into 10 performance deciles for that measure. And then they just assign cost measure points based on the percentile a group or clinician falls under. So that's what this is. So if you're in the 99th percentile, the highest costs, you're going to get about 1 point, probably 1 to 1.9 points. And these are just the ranges, right? So let's say you have a very clustered cost range, like you do for cataract surgery. It's a very efficient procedure, so there's not a lot of variation. That means that an outlier, because it's so clustered, could put you in the 99th percentile, one outlier in patients. So having this very clustered, efficient cost distribution has created problems where people who only have a $200 difference in average episode cost are seeing like a 5-point difference in their cost score. And again, each measures out of 10 points, so that's huge. CMS heard us and they proposed a solution. Rather than doing it the way they currently are, CMS is proposing to set the median dollar amount, so the median cost for an episode. Let's say the median cost for cataract surgery, for example, at 7.5 points. That's huge because right now we can see the median be either very low or up to 5. But this is acknowledging that there are costs outside of control, but also that not half of physicians are spending too much. So this is an appropriate, like, if you're around average, if you're around the median specifically, you're going to get 7.5 points out of 10 rather than anywhere from 2 to 5. And then they'll use that median to determine the other cutoffs. So rather than being based on percentiles, it's going to be based on standard deviations. And I have that listed out in this proposed cutoff. So if you're 2.75 standard deviations from the median cost, you're going to get 1 to 1.9 points. And that is a significant number of standard deviations if you know statistics. So this is a much more accurate way of determining who's high cost and who's low cost. So we expect more intuitive cost scores, ones that are easier to impact moving forward if this is finalized. So if you are going to comment on MVPs, please do also comment on this and say, good job, we like this proposal. So next up, there are some pretty significant, speaking of the cataract cost measure, there's a reason it's on my mind. There are some pretty significant proposed changes to the cataract cost measure. First, they're proposing to change the name. Currently, it's the routine cataract with IOL implantation measure. They're getting rid of the word routine. It doesn't actually impact the measure right now. My concern is that it's foreshadowing future inclusion of complicated cataract cases. So that's something to watch out for moving forward. They're also reducing the exclusions. So they're removing exclusions largely around glaucoma and macular degeneration, but they're actually removing of the codes about 62% of the codes. So that's a lot to dig into right now. Further analysis will come in future weeks, but it is a pretty significant reduction in exclusions. So that's something to watch out for if you're counting on a glaucoma or macular degeneration diagnosis, excluding a patient from the measure. If this is finalized, that won't happen. CMS said that when they looked at how this would impact measure scores, they didn't see a big difference in cost for patients with glaucoma or macular degeneration and some of the other exclusions that were removed, and that's why they were proposing to remove them from the list. They did say, however, that they will include them in a risk adjustment. We don't know how effective that will be, but at least it will be a variable that's considered. Next up, they're also proposing to increase the cost that can be assigned to the episode. So this is not triggers. This is not what starts the episode. It's the costs that are included when the dollar amount is being calculated. So currently, Omidria is the only Part B drug that's included outside of, anesthetics. CMS is proposing to add, however, both Dextenza and Ahizo to the list of expanded medications and services. They're also including emergency department visits and a whole cohort of other visits. So the assigned services will increase. Because this is happening for everybody, we're thinking that will probably even out. The big concern is, again, the reduced exclusions. Next up, there are several proposed new measures. And so this is where you can see the case minimums. For all of these new measures, the episode minimum is 20. That means at least 20 patients for the reporter, whether that's your group or you're doing it as an individual, got picked up on this measure for you. So we've got rheumatoid arthritis, chronic kidney disease, end-stage renal disease, kidney transplant management, and prostate cancer. They're all chronic condition measures, just like the diabetes cost measure is. So they include Part D medications. And there's an acute inpatient measure on respiratory infection in hospitalization. Now, I want to bring your attention to the rheumatoid arthritis cost measure. Just like the diabetes measure, it has that, when it comes to attributing the measure to a clinician, the clinician must have prescribed at least 2 condition-related medications to at least 2 patients in the 12 months prior to be considered someone who manages the condition. After the field testing, so after we saw if any of our clients got picked up in what was originally what was going to be proposed, they made a modification and there was no additional testing. The modification adds ophthalmic drops, that largely those used for dry eye, into the list of condition-related medications. We have asked CMS and their contractor Acumen to give us some more details. What is this going to look like for ophthalmologists? Could they run a report to see if more ophthalmologists got picked up? They said that they're looking into it, but I think it's safe to assume that ophthalmologists would get picked up under this refinement that they made, and it's very important to comment on it. Also very important is that this list of condition-related medications includes things like NSAIDs. So please do pay attention to this measure. Consider commenting to CMS that certain specialties that absolutely do not manage this condition, like ophthalmology and dermatology, for instance, should be excluded, rather than just relying on the 2 condition-related medications, because this cost episode measure has such a broad list that it's going to pick up too many people. Okay, and there's also a proposed modification to the inpatient percutaneous coronary intervention. We don't currently represent any interventional cardiologists, so we won't go into detail on that. And that's it for cost. I know that was a lot, but this next category, there's one proposed change. So we're going from hard to easy. For the EHR category of MIPS, the only change, and this is something we've been begging for, so go ahead and celebrate, is that starting in 2024, clinicians and groups who submit PI more than once, whether their EHR submits it on their behalf and they submit it through a registry, or they go in on a test, rather than getting a score of 0, if there's any deviation between the two, including if it's like one performance period starts a day later, you would get a 0 under current policy. Rather than that, CMS is proposing to take the higher of the 2 category scores. This is huge. We have had clients come to us and start working with us and get a score from a year before they started working with us of 0 in PI, specifically because their EHR also reported it, and the day of performance period start was 1 day different. So this is huge, time to celebrate, and they're starting it in 2024, not 2025 if it gets finalized. So again, if you're writing comments, go ahead and say yes, please. Oh, and quick reminder that starting this year in 2024, CMS did finalize a 180 consecutive day reporting minimum. So we have fewer than 180 days left in the year. If you haven't started on that, it's certainly time to get looking. There were no proposed changes to the measures, so I won't be going through these. There were no proposed changes to the attestation statements either. Although quick reminder that you now starting this year do have to attest yes to having performed the high priority safer guides annual assessment. So on that note, it's required under HIPAA, it's required under MIPS. Make sure you perform your security risk analysis this year. There are a lot of ways you can do it. You can do it on your own. You can use internal IT. You can use an outside consultant. You could do it with us. If you're already working with us for MIPS, we also offer security risk analysis services. And we can also do your annual safer guide assessment, saving you even more time and energy by having it all done in one place. So if you're interested, please do feel free to reach out. I promised you that one would be short, so now we're on to improvement activities. So big changes to improvement activities. Currently, you have to report on a certain number of improvement activities to get up to 40 points, which is the maximum improvement activity score. So there are high-weighted improvement activities and medium-weighted improvement activities. CMS is getting rid of all of that. They're proposing that in 2025, it's no longer going to be point-based. Everybody's going to be required to do the same thing, which is to attest to 2 improvement activities. There's no weighting, it's just any 2. There are exceptions to this. If you meet one of these exceptions, you only have to attest to 1 improvement activity. Again, no weighting, just any of the improvement activities. So the exceptions are any practices or clinicians that are reporting from a small practice, a rural practice, a non-patient facing practice, so that's people like pathologists largely, and radiologists, or a health professional shortage area. If you have that special status, 1 improvement activity is all that's required. Also, for, as I mentioned earlier, MIPS MVP, participants only need to do 1. There are some proposed changes to the inventory of improvement activities for 2025. There are 2 proposed new improvement activities. One is on lung cancer and one is on screening for cardiovascular risk. These aren't very applicable to our clients, so I won't go through them. This is just for your information. There are proposed modifications to 2 improvement activities. They're proposing to expand the COVID-19 staff vaccination requirement improvement activity to also include influenza and Hep B vaccinations. And for the engagement of patients through improvements in patient portal improvement activity, they're proposing to change it to require implementation of a new portal rather than just improvements, and specifically by clinicians who were not previously using a patient portal. So that's going to take that improvement activity off the table for, I think, all of our clients. So it's important to note. Now, even more importantly, CMS is proposing to remove 8 existing improvement activities, including everyone's favorite, 24/7 patient access. So if you are relying on that currently, it's time to start looking for another one. They're also proposing to remove closing the referral loop, which is another commonly used one. These other ones aren't as frequently used, but if you do use them, just know that they are proposed to be removed and likely will be finalized for removal regardless of comment. We have this list also on our blog, so feel free to check that out as well. So that brings us to quality, the last category. So just like costs, quality is a full performance year period. You can earn up to 60 points. You have to submit 6 measures, including 1 outcome measure, and is worth 30% of your MIPS final score. There are no real changes here. You still get the small practice bonus, and you could still report via most of the same mechanisms. I will note, this is not a proposed change for this category, but this was a finalized change last year. So this was finalized already last year. That starting in 2025, you cannot report through a health IT vendor anymore unless they have submitted a self-nomination and been approved as a qualified registry or a qualified clinical data registry. And this is because that allows for more oversight. There have been a lot of issues with people that reported through their EHR, got audited, and then found a whole bunch of errors. So this is really to protect the reporters. No major changes to measure submission and general measure scoring. The big change, though, is that previously the data completeness threshold at 75% was only finalized to continue through performance period 2026. CMS listened when we said it's hard to go above that, and they extended that by 2 years in their proposed rule. So instead of ending in 2026 and then being open for a new proposal that could be higher, it's at least going to stay through 2028 at 75%. And there are some measure changes as well. Because of all the specialties that we represent, being ophthalmology, dermatology, orthopedics, podiatry, PT, OT, and otolaryngology, we do not have time to go through all of the measure changes that are proposed. I will summarize it by saying that there are 9 proposed new measures, 66 existing measures with substantive changes, and a proposed removal of 11 measures. Now, while we don't have time to go through it in the webinar, we will be posting today our top changes report on our blog. And that PDF will have an outline of the changes to every measure for every specialty that we represent, broken down by specialty, so it's easy to find. Another change that is proposed is how some measures are scored. Not all, just some. CMS is proposing that for some topped-out measures, they will apply flat benchmarks, meaning every measure that gets this performance rate range will get these points, these available points, regardless of how everybody else does on the measure. This will only apply for measures in specialty sets with limited measure choice and a high proportion of topped-out measures. CMS didn't really describe this in much more detail. We don't know which specialties this would apply to, so that's all the detail I really have right now. It doesn't really describe a lot of our specialists, so if we do end up getting a flat benchmark, it'll be a pleasant surprise. So as I promised, we're going to tell you how to submit comments. So first off, I want to kind of talk about how a rule becomes implemented. Congress passes a law, in this case MACRA, as we talked about earlier. The agency looks at it, they write up what they think is a good plan for implementation, and they propose it to the public. That's a proposed rule. For proposed rules that have what's called significant financial implications, like for instance, a fee schedule, which contains the QPP or MIPS, a 60-day public comment period is open. If it's a different kind of rule, it might be shorter, but for this, it's always 60 days. In that time, you can look at the rule and submit comments to CMS, being like, hey, I like this, I don't like this, here's why. Then CMS will publish they'll review the comments, they'll respond to the comments in the final rule, and then they'll publish the final rule that will set the rules for the road and give responses to general comment categories. They don't respond to every individual comment, but comments usually fall into certain umbrellas, like we don't like this because this. So they'll respond to that umbrella of comments for each proposed change. For this rule, comments are due by September 8th at 5 p.m. Eastern Time, specifically Eastern Time. CMS will release the final rule either the last week of October or the first week of November. And then we'll see what's finalized. But really, your voice makes a difference. We, as an organization, will be submitting comments, which we will publish on our blog. If you would also like to make your voice heard, which I encourage you to do, this impacts you day in and day out, please do write comments. If you follow our blog in the coming weeks, we are going to publish more about the proposed rule, and we're also going to publish a guide on how to submit comments, including a template letter so that you have to do as little thinking as possible. And it'll walk you through how to submit comments online. And that actually brings us to the end. I know I raced through it. I was worried I'd be short on time. So we have plenty of time for questions. Let's open it up to Q&A.
Hi, Jessica. This is Renee. First thing that I wanted to mention, when you first brought up about the blog, I went ahead and posted it in the chat. So it includes the blog link,
fantastic.
and then that includes, yep, absolutely. So that includes the PDF that Jessica was referencing.
Thank you very much, Renee.
You're welcome.
All right.
So it looks like Jessica saw a question that came in about MVPs. So it's like traditional MIPS versus MVPs. And do you have a recommendation on reporting via traditional MIPS versus MVPs in 2025?
That's a really good question. So that answer is definitely going to be very personal. As you saw in the proposed MVPs, there are certainly some issues, and it can be hard to, because of the limited quality measure choice, find measures that apply to you. Now, if you happen to have a lot of measures, like cataract does and a couple of others, it might be worth it to take a look, because then it's only 4 measures. And if you're a dermatologist and you find measures that work for you, it also might be worth taking a look, because not only is it just 4 quality measures, but would be 0 chance of being picked up on total per capita cost or any cost measure other than the melanoma resection cost measure. That being said, it can be difficult to report MVPs, but most importantly, if you want to give MVPs a shot and you want to see if maybe you can get a higher score, if you report both MVPs and traditional MIPS, CMS will take the higher of the 2 scores. So there's not much risk if you're going to do both.
All right. Checking to see if any more questions came in, which all of you obviously can put it in chat or in the Q&A section, whichever you prefer. All right, Jessica, so this is a question about promoting interoperability. So right now it's 180 days, so proposal 2nd year in a row for 180 days. Do you anticipate that the performance period, time period would increase in the future beyond 180 days?
Yes. I think that it will. I think that it will be a while, because right now they've made it so that it mirrors what's required for the hospital. So they like to align regulatory requirements across programs. I do think that CMS wants it to be longer. There will be a lot of pushback. I think there will be a proposal to make it longer. I don't know, maybe 5 years, but there will be a lot of pushback. If they do finalize it, CMS has indicated that they are aware of how difficult it can be to aggregate data across different EHRs if you transition, and how the transition can impact performance scores. So if there is a transition, there will definitely be an exclusion available. So
Okay.
yeah, but I don't see this as an immediate future problem, no.
So also speaking of exclusions for PI, so small practices, would you anticipate that small practices may eventually be required to report on the PI category?
There has been no discussion on this whatsoever by CMS or in any meetings with CMS. So I can't say for sure, but I can just say it's not currently under consideration.
All right. So for the cost category,
yeah,
I know you talked about that there were a lot of changes for the cataract surgery measure.
yes.
So someone saying our practice didn't score well on the cataract surgery measure and the preliminary, like the 2023 scoring. Is there anything that can be done to improve the score, and considering some of the upcoming changes? Kind of a loaded question, I know.
For 2023, the score you have, unless you can find an error in the score, like last year, for instance, in some of the reports, we found duplicated services and we notified CMS and they recalculated and reissued scores. Unless you can find an error, there isn't much hope, unfortunately, of changing your 2023 score. Moving forward, this regulation just recently came out. There's a lot of digging that all of us in the regulatory space are still doing. The decrease in the number of exclusion codes is something I want to dig into more and see what kind of impact it will have. CMS again has said that there wasn't a significant difference between the costs were they to include those rather than excluding those conditions and the current cost distribution. That being said, it's certainly important to look into. I don't know that if you keep doing what you're doing now, that's going to change anything for your score. The only thing I can think of is that by not excluding those patients, you'll have a larger pool of patients, so any outliers will count less. But that certainly will not be applied until 2025's cost score, if it's finalized.
Okay. Same question or similar question came in about melanoma resection. Would you also say kind of the same exact feedback where they didn't score well on that in the cost category?
Yeah, there are no proposed changes to that measure. So
okay.
Yes, it's the same feedback. That the score you have is the score you'll get unless you find some errors. I was in a meeting with CMS and specialty societies yesterday, and someone did ask why these scoring changes weren't proposed to be retroactive, starting with the 2023 scores was specifically the question. And CMS said that there are legal requirements that they have to meet to make retroactive changes, and they were not able to get that approved. So it definitely will not be applied retroactively.
And it sounds like at least they made the effort based on what you heard in the call. Okay.
Based on what I heard, it was something they looked into, but were unable to do.
Does anybody want to unmute themselves to ask a question if you feel like your question is better to just ask verbally? Or you can raise your hand if there's a question. Whoops, sorry, I watched. I don't know if y'all heard that. Sorry. It's 12:47, guys. There's kind of, it sounds like a general question, obviously, with quality, talking about MVPs and traditional MIPS. Oh, geez, I'm sorry. I have to, it's the way I'm standing. Do you recommend if we should report on the quality category out of just our EHR or use a registry, which would add cost? Do you have any suggestions on that?
Well, I actually think that you're probably the better person to answer this since you do implementation, but I do want to note and flag before I pass it over to you, Renee, that unless your EHR self-nominates and is approved as either a qualified registry or a qualified clinical data registry, beginning in 2025, you will not be able to report using that system. You will have to use a registry or a clinical data registry, not a health IT vendor.
So in addition to what Jessica just said about the EHR, some other things to take into consideration is the cost, how much the registry would charge relative to what could your total score impact be for the MIPS category and any kind of financial impact as far as your Medicare Part B allowed charges. So taking that into consideration, that the cost of the registry may be worth it. Because of that, there's also in a registry QCDR measures, which are the Qualified Clinical Data Registry measures that are available through primarily through an academy's website or an academy's dedicated MIPS registry, like Verana Health houses the IRIS registry for AAO, Dataderm houses it for AAD, and so on.
Yeah, and only qualified clinical data registries are allowed to offer those measures.
And even ones that aren't approved, or the ones that are directly linked to the academy, it is also a case-by-case basis and can be added charges. Even for a QCDR registry, they may not even be allowed to report on some of the QCDR measures. So you definitely get a lot of additional measures to report on that if you do it through a registry instead of an EHR. And then also an EHR, I mean, there may not be as many specialty specific measures that are available. And the ones that are they relevant to your specialty? Are they difficult to score well in? So a lot of those things would be taken into consideration when you're deciding that. So would be a lot of factors.
Yeah.
Anything else, Jessica?
Yeah, there may be an option as we get closer to 2025, because again, this was finalized in last year's rule. So this is not a proposal that you can comment on and CMS will overturn it. It's already final. But there may be more of a push by EHR vendors to make your data more available so you can upload it yourself, rather than using what's called a third-party intermediary, because most EHRs will do it for you now, and that's them being a third party that is an intermediary between you and CMS. And in order to do that, starting in 2025, to be that third-party intermediary, they would have to be either a qualified clinical data registry or a qualified registry. So there may be more opportunities for you to get your data and then upload it to the portal yourself. But as of now, starting in 2025, not this year, but in 2025, it's looking like registries and QCDRs are going to be more standard.
All right. Anybody have any questions even about what we just covered, or if you want to raise your hand and ask a question verbally? All right, Jessica, I know this wasn't mentioned specifically, but another question came in about the PI's this wasn't mentioned specifically in the webinar, but the promoting interoperability's electronic case reporting, that there's the option 2 requirement for 2025 versus option 1.
Yes.
Can you explain that about what's required for option 2?
Yeah, so starting in 2024, well, starting last year, you had to, in addition to saying, yes, I participated, you had to indicate what level you participated in the data exchange for the public health and clinical data exchange objective. So that's, immunization registry, e-case reporting registry, or like a QCDR or what have you. For any of those measures, you had to say, I was either option 1 or option 2. Option 1 is basically I have registered and I'm working to get my EHR mapped well to send the data. So that's called registration and pre-production. Option 2 is called full production. So basically your EHR is just automatically actively sending the data to, in this case, the electronic case reporting registry for your state or region. Starting in 2024, you can only be in option 1 for 1 year. The exception to that is if you change registries for that measure. Let's say you have moved, you still have the same TAN and the same MPI, but you have moved to a different state, so you're using a different electronic case reporting registry. Then that clock would start over and you get one year again. So does that answer the question completely? Renee?
Yeah, I think it does. Absolutely.
Okay,
And if anybody has a follow-up question for that based on what Jessica just said, go ahead and throw that in or raise your hand to unmute yourself. All right, so for the PI category, again, the direct mail receiving measure. So what do I do if I haven't received any summary of care CCD documents for any referring providers.
Oh, that is tricky. And I do have tips on that, but Renee, I do believe you are, as the implementation person, the best suited to respond to this one.
So one of the things that we always suggest to our practices for this scenario, which also is very common, it can be challenging to speak to a practice and ask, what is your direct mail address? What's your HISP address? What's your secret email? And usually it's, here's our regular email, or I don't know what you're talking about. So we try to explain it's an EHR email delivery system that's very structured from one EHR to another. Even still, a lot of practices may not use it or be aware of it, or whoever you talk to may not be aware. So for our practices that we work with, which would be something that if you're not working with this, you'd be able to benefit from, is we ask them, okay, the top referrals that you receive from, can you ask that practice what EHR they're using? For many of these practices that have struggled with getting even one, we've often been able to tell the other practice, what steps they need to do to send it. Because we work with, I believe, about 20 EHRs. So if it's an EHR we've worked in or have familiarity with, we should be able to give some steps, and that's allowed our practices to be able to score. So it can get a little bit creative and tricky. Some of it is, who do you talk to? But we do like to start with that EHR question to see if we can help just through the knowledge that we have internally.
Yeah. And if you're not working with us, first off, we make your life easier. So please do. And I've got information about that on the next slide, which I will pull up as I answer this question. But if you're not, my recommendation, very similar to Renee, is if you know someone that has referred to you that is on the same EHR and you know how to send it, you can tell them how to send it as well. So it does stink that you have to go through this roundabout way, but CMS's goal with this measure is to get people to share information electronically. So they aren't going to, because we've requested this before, they aren't ever going to make an exclusion if you haven't received any summaries of care. They want there to be pressure on the people referring you to send you a summary of care. So unfortunately, it requires a little bit of legwork.
Unfortunately. It doesn't look like we have any other questions. I know we're almost at time, but just want to pause to see if anybody has anything else, or raise your hand. All right, hand it back to you, Jessica.
All right, great. Well, this has been the 2025 proposed rule webinar for MIPS. We had to cover some things at surface level. Again, if you check out the link we put in the chat, or you go to our blog, you'll be able to see more details, particularly on the quality measures and the proposed changes. If you want to work with us, please feel free to email us at mipsconnect@anatomyit.com. That's MIPS, M-I-P-S, the word connect, @anatomyit.com. And to check out our blog, it's simple. It's anatomyit.com/blog. So I hope that our resources are useful. I hope this webinar was useful. Feel free to email us any follow-up questions that you have. And I hope you have a wonderful day. And don't forget to comment on the rule, please.